Hello everyone, my name is Anett Szabó and my topic is male infertility, functionality and surgery. I work at the Andrology Center in the Department of Urology, and my vision is to educate patients regarding our findings on the risk factors associated with male infertility, and my mission would be a larger scale education. We have 4 topics, and the first 2 are related to sperm DNA fragmentation, and the second 2 are about the patients that we've seen at our center. The first one is risk factors associated with sperm DNA fragmentation. As a quick background, I have to say that infertility rate is quite high in developed countries, and sperm DNA fragmentation impacts fertility. Some of the risk factors associated with sperm DNA fragmentation are lifestyle, diet, obesity, smoking, and so on. And our aim was to investigate the effect and possibly the extent of known and suspected risk factors on sperm DNA fragmentation. Our clinical question was what is the link between sperm DNA fragmentation and the risk factors? And for this, as a population, we looked at every male. The exposure was risk factors, and the comparison was no exposure to that certain risk factor, and the outcome in every case was sperm DNA fragmentation. And our hypothesis was that there is a link between the studied risk factors and sperm DNA fragmentation. We did the selection, and we ended up with 27,000 articles, and from these we could extract data from 217 articles. And altogether we ended up with 37 risk factors. Just as a quickly a few words about the upcoming first plots. You have to know that there aren't exact cutoffs for the optimal range for sperm DNA fragmentation, but what we can say is that the lower this value is, the better. Optimally, let's say, it should be below 25%, but between 20 and 30%, you have to expect some adverse pregnancy outcomes. But 25 to 50% of sperm DNA fragmentation, those sperm cells are still eligible for the use in IVF treatments for in vitro fertilization. We did subgroups according to the sperm DNA fragmentation assays used, and we will do further grouping according to the fertility status of the males. These are some of the first plots that we have, and I'm going to show you some of them. Our first risk factor is varicocele. Our hypothesis was that patients with varicocele would have a higher sperm DNA fragmentation than those patients who did not have varicocele. You can see that the mean difference is 11.37% of sperm DNA fragmentation. The heterogeneity was quite high, and what you can also see is that the results came out to be both statistically significant, and 11.37% is also a clinically significant difference. Our next one was abnormal glucose tolerance. Our hypothesis was that patients with abnormal glucose tolerance would have a higher sperm DNA fragmentation than those who had a normal glucose tolerance. Our mean difference came out to be 13.93%. The heterogeneity was again high, and in this case we also got statistically and also clinically significant results. Our next risk factor was BMI. Our hypothesis was that patients with normal BMI would have better sperm DNA fragmentation outcomes than those with not normal BMI. We did groups according to the BMI that we looked at. In every case, we compared the patient's BMI to normal patient's BMI. On the top, you can see underweight patients compared with normal, then overweight and obese. What you can see here is that I unfortunately switched the 2 groups on the top, and so the mean difference would actually be minus 1.54%. In the first case, you can see that the heterogeneity is low, but in the other 2 cases, it is high. For the underweight versus normal patients, we had a statistically significant result, but not for the other two groups. But what we can see here is that as the BMI increases, the sperm DNA fragmentation becomes worse. It also increases. So it goes from minus 1.54 all the way until 3.27%. Our next risk factor was alcohol consumption. Our hypothesis was that those who consume alcohol would have a higher sperm DNA fragmentation than those who do not. We did groups according to how much the patients drank. On the top you can see heavy drinkers compared with abstainers, and then moderate drinkers compared with abstainers. Again, you can see here that the results did not come out to be statistically significant, nor would it be a clinically significant result either. But what you can see is that according to so as the patient drinks more alcohol, the amount of DNA fragmentation increases from 0.88% in moderate drinkers versus abstainers to 2.92%. The next one is smoking. Our hypothesis was that smokers would have a higher sperm DNA fragmentation than those who did not smoke. Again, we did grouping according to the amount of cigarettes smoked. On the top you can see heavy smokers compared with non-smokers, and then moderate smokers compared with non-smokers. The mean difference came out to be 9.32% in heavy smokers versus non-smokers and 2.93% in moderate. You can see that the heterogeneity is again high. And in the first case, it was a statistically significant result, not in the second one though. And in the first case, it's also a clinically significant result that the difference of almost 10% in sperm DNA fragmentation would have a high impact on fertility. As a conclusion, we can say that varicocele and abnormal glucose tolerance increases sperm DNA fragmentation, but we would need more studies in the other three, for the other three risk factors. Some of the strengths include that all risk factors that studied up till now have been included in our study. We have a high number of articles and also a high number of patients. And some of the limitations are that we have no longitudinal studies included. We can't exclude all the risk factors and look at only a single one. We have a low number of studies for some risk factors, and we have high heterogeneity in most cases. As an implication for practice, we can say that we can give specific suggestions for each patient concerning the risk factors they're being affected by. And for research, we need more research in relation to smoking, alcohol consumption, and BMI for sure. And we would need to establish registries. And I have three other projects. The second one is efficacies of interventions aiming to improve sperm DNA fragmentation. We did the selection and we ended up with 107 articles from which we would need to extract data from. And the third one is non-palpable testicular masses and their testis-sparing surgeries. So far we have included 31 patients, which is a high number, and we keep including more and more patients. And the last one is the prediction of sperm retrieval in non-obstructive azoospermia via an artificial intelligence software. For this, we have 91 patients up till the point that the software has been made for us. But since then, we have a lot more patients, and we're going to focus a bit more on this one from next week. And our goals are to submit the first two projects by the end of May, and the second two by the end of October. And as a finishing quote, today is the first day of the rest of your life. Make it worthwhile to continue. Thank you for your attention.
Thank you for your presentation and congratulations on your work. I wanted to ask you that on your first project, what you mentioned, the risk factors for sperm DNA fragmentation are reversible. So do you think that if you give advice to the patients for example, to quit smoking or lose weight, that this tendency of DNA fragmentation could be reversed as well?
Well, we hope so. We do know that changes in lifestyle can have an impact on it, but we will see it in more detail with our second project with the interventions aiming to improve sperm DNA fragmentation.
Thank you.
Thank you.
Okay, I have a question. Thank you for your presentation. Regarding the risk factors, you mentioned moderate smoking and heavy smokers. Have you find the definitions in the studies are exactly the same, or how do you define moderate smoking and heavy smoking?
Well, if the study said that they did grouping, well, if they said that this is a group of heavy smokers, this is a group of non-smokers, we accepted their own definitions. Usually they were the same. If they said, like, for example, this patient smoked, I don't know, 11 cigarettes per day, then we looked at the WHO guidelines for the cutoffs for grouping them, and we grouped them ourselves then.
Okay, thank you.
Thank you.